Psych.
Hey, and welcome back to Psych Nurse. We're going to be talking about handovers today and the importance of having some sort of structure to your handover and what it can mean for you, what it can mean for your patient, and what it can mean for your organisation. And the formulated handover structure that we're going to be using today is ISBAR. Just to give you a little bit of background on handovers themselves, the Australian Medical Association say the safe transfer of any patient care requires effective handover between clinician to clinician, and the aim of any handover is to achieve the efficient communication of high quality clinical information at any time when the responsibility for the patient's care is transferred. Cochrane, the organisation, goes on to state that a nursing handover occurs when one nurse hands over the responsibility of care of a patient to another nurse. So, as an example of that, at the end of the nursing shift, say, and on average, nursing handovers occur around 3 times a day for each patient. And Cochrane goes on to say that failing to mention or grasp information may result in delays in inappropriate treatment or even a failure to provide appropriate care. Consequently, an accurate handover of clinical information is essential to ensure the continuity of care and the patient's safety. So we've got 2 varying views there from a medical perspective, but from a nursing perspective, it does show you the consequences. Really, it gives you an idea of the consequences of failing to give a good handover. And we all give a reasonable handover, we think, but at times our audience can make a difference on how we actually present that handover. For instance, you might be sitting with nurses that perhaps you feel have got much more experience than you, or perhaps you might not feel that the care they provide is on the same par as yours. And with constant interruptions that can occur in handover, and you can tell this when you go into the handover itself, because it can seem really disjointed and disorganised, and people interjecting, or talking about stuff that's, to be quite honest, it's not objective. It's pretty much subjective. It's their opinion, and not that your opinion's not important, but it's their take on what they think a person's saying or why they're particularly saying something. So you can find that in your handover. So ISBAR is a formulated procedure, and I'll go into a little bit more about it now. So what is ISBAR? Okay, so ISBAR is a framework that represents a standardized approach to communication, which can be used in any situation, and it stands for introduction, situation, background, assessment, and recommendation. So, what are the advantages of using this particular framework over another one? Well, the ISBAR framework ensures that there is a completeness of information, and it also reduces the likelihood of any missed data. And it's an easy and focused way, I guess, to set expectations for what will be communicated. And it ensures a recommendation is clear and professional. It gives confidence in communication and focuses not just on the people who are communicating, but on the problem itself, which is what I was kind of talking about there. It's not about what the person in front of you is doing or saying. It's about what they're actually communicating and how they're communicating it. And that's the part which I think as nurses we need to sometimes have some discipline around. And I think it's okay to express opinion, banter, but when someone's handing over, I just think it's so important for them to get their message out, they're getting ready for it, and for you to be in a state to receive it. And I think that's just respectful. So, why would I use ISBAR? Okay, so some of the key reasons for using ISBAR is that it's portable. Okay, you can carry around. It's quite memorable and it's easy to use. And when I say you can carry it around, I mean it can be used in various situations, which I'll go into. So it can be used to present information clearly in any situation, and it helps you organise what you're going to say, and it standardises the communication between everyone. Where did it come from? Where did ISBAR come from? Well, originally ISBAR was ISBAR, and it originated in the US Navy for use in nuclear submarines. I know. It's also been used by the airline industry because it assists the transfer of important information in a limited time. ISBAR has been adopted by most or by many healthcare organisations across the world. And like some other users of the framework, healthcare added the I. Of course, they would have had something. We can do it better to stand for introduction. And you know, although the introduction may not always be super important, particularly if there's a continuity of shift, I think it is really important to remember the introduction when you're handing over to new people or when you're handing over to a different discipline, particularly if that discipline has just come into your environment. Okay, so the I introduction is to ensure that the person talking identifies themselves, the person talking confirms the identity of the person they are talking to, and the person initiating the conversation confirms that they are the attention of the person that they are talking to. Sorry, should I say not the person are the attention, should I say the person has the attention of the person that they're talking to.
Psych.
The ISBAR framework itself can be used in any information handover situation. So we don't just have shift changes, for example. We could be discharging our patient into the community services, we could be transferring our patient to another hospital or somewhere within the hospital. You know, we often have patients that, say for instance, may have self-harmed or something like that. So they might need specialist medical attention, they might need cannulas installed or something like that. So what you really want to do is be able to transfer them to another ward. Of course, you know, good handovers reduce anxiety and allow people to understand exactly what's going to happen when the person gets there. So you might be doing those intra-hospital transfers. There might actually be time-critical situations such as an medical emergency, you know, code blues. I'm not too sure what you might call them in your environment, but I call them code blues. Or evacuations. You can use them in procedure-type documents, reports, memorandums and briefings. Because it focuses on the issues in hand, it means that for those of a different discipline and seniority will speak the same language too, which I think is so important, because we tend to, when we're talking to doctors or anybody at the medical treatment team, there can be this feeling of seniority or you know, the hierarchical type situation. But I think if we're all speaking the same language, it kind of allows us to quickly understand, and the expectation is much more on an even playing field. So more effective communication. ISBAR creates a shared mental model for transfer of relevant, factual, concise information between clinicians, and it flattens that hierarchy, so it eliminates the power differences that may inhibit information flow. So doctor to doctor, nurse to nurse, nurse to doctor, doctor to allied health, to and between ward staff and housekeeping and clerical staff even. So that kind of gives you a little bit of a background into what ISBAR is, why we would use it, and you know, the advantages of using it, and the fact that it's a portable, memorable thing. And I'd like
Psych.
Okay, so you start with your introduction, who you are, you're talking about what shift you're on, the date, whatever. This is probably more relevant when you're talking to people that haven't been on your ward before, or you're talking to fairly new people. And the situation is that John, your patient, the guy that you're handing over, is a 48-year-old man who has been admitted due to a relapse in his schizophrenia. He has been with you for the past 2 days, or he's been with us for the past 2 days. He is currently non-compliant with treatment, and he's on 10 milligrams of olanzapine BD. Now, John believes that others are out to try and poison him and steal his thoughts, and he remains mostly isolative really, and only comes out for meals with prompting, and then he will insist on sitting on the couches to eat his meals. John's not attending to his ADLs, and he rarely engages, and he appears to be frightened and hypervigilant around others. And that kind of gives you the situation of why John is here and how he's presented initially at his admission. So you really need to then give your audience a bit of a background on John. John has a history of non-compliance and has been a client of your area for around 25 years. He's actually a frequent flyer to the unit, and this in fact is his third admission in the last 18 months. He's case managed in the community and has a case manager change in the last 4 months, and the relationship is described as a bit strained. John has a history of showing aggression and irritability, voicing concerns, particularly when he's scared. So that gives you a bit of a background of what John's baseline is, and how long he's actually been in the system. Okay, and then you move on to your assessment of the last 8-hour shift that you've observed. So it might go something like this. I believe John to be currently psychotic, and he has persecutory beliefs about others and the environment. He's paranoid, and I feel he's not ready to fully engage yet, and the medication is not at its therapeutic level. I believe John to have a moderate risk around vulnerability and damage to his reputation, and a risk to others, particularly when he's feeling threatened. So that's kind of gives you an observation and allowing your audience to understand that you've actually been engaging or trying to engage with John, and you've made some quite good observations about that. So you've given a bit of a weight to your assessment. It doesn't sound like you've kind of sat there in a corner of the room and just watched him all day. You kind of spent a little bit more time. You know that he hasn't attended to his ADLs. You know that he seems hypervigilant, and particularly around the certain times. And you're giving some weight to your story. And then finally, and most importantly, is your recommendation. So you are recommending that to continue monitoring mood and mental state, and encourage a therapeutic alliance, monitor risks, and when reviews are occurring, ask the treating team to offer some PRN lorazepam, and this is for John's anxiety and agitation. Also talk to the TL about a plan to move John to time out if he becomes agitated and threatening towards others. You're kind of thinking about the guy's future. So that's like an example of what you would typically say in a review. Now obviously you've got your own style and your way of doing things. Mine's a bit wooden today because I'm looking into a camera, but normally I'd have a lot more lighter and probably humour around what I'm saying, to be honest. So we've looked at overall today what is ISBAR, and that being the introduction, the situation, the background, the assessment and the recommendation. And the advantages of using this formulated handover is that I think it puts everybody on an even playing field. It also installs confidence in the people, your audience, about what's going on, and also allows you to take a bit of ownership to the sort of work you've been doing and your expectation of what you expect to be done. Why would you use it? Well, I think personally from my own experience is that I don't like all the interjection and everything you get sometimes in handover and people offering their subjective views. I would prefer to keep things objective and then be subjective afterwards if we need to be. So where did ISBAR come from? Well, initially it was ISBAR, as I said, from the US Navy and used in the airline industry. military and health adopted it but added in the I